Good evening, chairpersons, ladies and gentlemen. I'm going to be giving you a summary of what the current international guidelines have got to say with regards to the management of gastrointestinal stromal tumors. So just a quick recap. These are rare tumors, the most common soft tissue sarcomas of the gut, predominantly in males. 60 to 65 is the median age, and as we have just heard, the most common site is the stomach. They arise from the interstitial cells of Cajal. The etiology of GISTs, nobody exactly knows, but what we do know is that 90% of these GISTs are either c-KIT positive or PDGFRA mutation positive. Rarely they are positive for BRAF and NF1 mutations. So over the next 10 or 15 minutes, everything that you're going to be hearing from me is going to be from the following guidelines. The first is the European Society of Medical Oncology guidelines published in 2018 in the Annals of Surgery. The second is the British Sarcoma Group guidelines published in the year 2017 in Clinical Sarcoma Research. And the third and possibly the most exhaustive guidelines is the NCCN guidelines on soft tissue sarcoma published in 2017. It has a chapter on GIST amidst all other chapters. That particular chapter has in fact been updated in 2018. And we're also going to be hearing a bit about what the guidelines from this part of the world has got to say. Almost all the guidelines have categorized the management of GIST into loco-regional disease management and metastatic disease management. With regards to management of tumors locally or loco-regionally, the three most important factors that have been taken into consideration throughout in all the guidelines are number one, tumor size, number two, mitotic index, and number three, primary tumor site. Although tumor rupture is not an essential part of risk stratification, it has been an important factor in almost all the papers that you read about in GISTs, and it has been shown to have an adverse prognostic factor. By and large, gastric GISTs tend to have a better prognosis than non-gastric GISTs. Amidst the non-gastric GISTs, the rectal GISTs seem to be doing poorly, possibly because of the fact that these are quite aggressive in nature. If the GISTs are in the stomach or in the distal esophagus or in the proximal duodenum, and if they are less than 2 centimeter, there is a role for close surveillance. However, if it is anywhere outside this particular area, distal esophagus, stomach, or proximal duodenum, i.e. non-gastric GIST as they call it in the guideline, it could be of any size. The standard advice is go ahead and excise it. If you opt to go down the surveillance path for selected cases, you've got to keep a close eye on it and deal with these patients once they become symptomatic or once they increase in size. How you do it? Well, endoscopic ultrasound is a very useful modality to follow up these small lesions. But by and large, the most important radiological investigation that is being employed for GISTs all over the world is a CECT. If the tumors are small and if they are located in these areas, which is distal esophagus, stomach, or duodenum, an EUS biopsy is recommended if they are, if they are less than 2 centimeters. In rectal GISTs, there is a role for MRI, but in many centers choose to stick with just a CECT because the the reports of CECT are in some centers as good as the MRI reports. As a surgeon, our priority should be in achieving R0 resection. There is no role for a standard lymphadenectomy in GISTs. However, if the preoperative investigation, radiological investigation, or any histological result suggests that there is a lymph node positivity, there is a role for lymphadenectomy of the positive lymph nodes. If the GIST is large and if it involves adjacent organs, an en bloc resection is what is recommended. For example, if there is a large posterior gastric wall GIST and if it involves the body of the pancreas or the tail of the pancreas, it is recommended that you do a wedge resection of the stomach and a distal pancreatectomy. But if you feel that an R0 resection is going to cause a major functional sequelae, you're better off going for neoadjuvant therapy, and the neoadjuvant therapy is almost all the time imatinib. The standard recommendation is imatinib therapy for 6 to 12 months. If imatinib does not help in reduction of the tumor size or any progression in the tumor characteristics, improvement in the tumor characteristics, or if it is not acceptable to the patient due to side effects, excuse me, it is fine to go ahead with the resection. And this is one of the few things in surgery which is quite unique. You don't want to accept an R1 resection in any cancers, but in GIST, you're perfectly fine to go ahead with surgery and accept an R1 resection provided they are low-risk tumors, because studies have shown that R1 resection fare no worse than R0 if the GIST tumors are low-risk tumors. With regards to post-op therapy, adjuvant therapy with imatinib is usually for 3 years. Mutational analysis is mandatory for all these patients, although mutational analysis is not part of risk stratification. As we just heard, the most common mutations are the c-KIT mutations. They occur in about 95% of GISTs, the proto-oncogene being CD117. There are other mutations as well. The important thing here to remember that if the mutations for PDGFRA and NF1 are present, it's not a wise idea to go ahead with imatinib therapy, because usually these patients are resistant to imatinib. Within the group of c-KIT positive patients who are sensitive to imatinib, the ones who are exon 9 positive, KIT exon 9 mutation positive, they would require a higher dose of imatinib, which is 800 milligram once a day, as opposed to the standard dose of 400 milligram once a day. With regards to metastatic disease, imatinib is the standard treatment. The guideline doesn't mention about any specific duration of treatment for metastatic disease. It's usually lifelong. And the interesting thing about treatment of metastatic disease is that if the patient develops isolated metastasis or recurrence in the area which has been previously operated upon, unlike adenocarcinomas or unlike squamous cell carcinomas, there is a role to going back in and performing a re-resection, even if it means going back and removing a portion of the liver. There are other treatments also available for metastatic disease, and that's particularly in the case of liver radiofrequency ablation, but most of the time these are reserved for tumors which are less than 3 centimeters in size, and almost all the time a PET-CT is performed before going ahead with such innovative treatments. If there's a confirmed progression on imatinib, in other words, if the patient's tumor keeps progressing despite imatinib therapy, the second line treatment is sunitinib, and usually that's given in a dose of 50 milligram daily, or a 4-week on and a 2-week off basis. If they're resistant to both imatinib and sunitinib, they go on something called regorafenib. Rarely, recurrences can happen in a single site, and if the recurrence has happened in one particular site, and if it has happened despite the patient having imatinib and imatinib or sunitinib, radiotherapy can be employed. But that's an extremely rare situation. How do you assess the response to these kind of treatments? Well, you look at the tumor size and the tumor density. With GISTs, unlike other tumors, tumor density has got an important role to play, because there can be response, there can be good progression, there can be good regression of these kind of tumors even without reduction in the size. And there's a very characteristic term mentioned in the literature which is called nodule within the mass, and that's usually a sign that the tumor is regressing, although the tumor size can remain the same. FDG PET apparently is very useful in detecting early progression of GIST of response of GIST to treatment. The optimal follow-up for these patients is not clear in any of the guidelines. It's still under evaluation. When relapses occur, they occur either in the liver or the peritoneal cavity. Metastases in the bone or brain are extremely uncommon. How do we follow up these patients? Well, depending on what category of risk they fall into. If they're high risk, they have something like 3 to 6 monthly cross-sectional imaging for 3 years, 3 monthly for 2 years, 6 monthly for 3 years, and annually for 5 years. A bit less frequent if they are low to intermediate, and if they are very low risk, there is no routine follow-up required, provided the primary surgery had an R0 excision on the pathology report. Yes, this is a lot of radiation. So in patients who you think could end up getting so much of radiation over a 2-3 year period, MRI can also be used as a suitable alternative follow-up investigation modality. So most of the information that we have seen so far from the Western guidelines apply to this part of the world as well, except for a few things which I thought was interesting in the Asian guidelines. Thanks to the cancer screening program in the Far East, there's been an increasing incidence of asymptomatic submucosal tumors detected in this part of the world than in the West. Secondly, there's a lot of emphasis on endoscopic resection of GIST for smaller ones, less than 2 centimeter GISTs in the West. However, the Asian guidelines suggest that laparoscopic approach is preferable over endoscopic resection because they demonstrate the problems associated with pseudocapsule damage in the endoscopic resection. And in the Asian guidelines, there's quite significant information written about the indications for laparoscopic surgery, and they talk specifically about favorable locations, the greater curve of the stomach, jejunum, and ileum, and apparently the outcomes of laparoscopic surgery are in par with open surgery, provided you choose the location of GISTs. So I'd like to conclude by summarizing the recommendations in all the 4 guidelines that we have just been talking about. The standard treatment for localized GISTs is complete surgical excision. There is no need for lymphadenectomy. It's a 3A. Well, 3 refers to the level of evidence and A refers to the grade of recommendation. So each of it has got a number and an alphabet next to it. If R0 surgery with no major sequelae is not feasible, you go for neoadjuvant therapy with imatinib. If you feel R0 resection has got some major functional sequelae, it is fine to go ahead with surgery, and an R1 resection is acceptable. If the tumor progresses on 400 milligram of imatinib, the medical oncologists usually increase it to 800 milligram daily, with the exception of the ones who are having certain insensitive mutations. Adjuvant therapy with imatinib is usually for a period of 3 years. In a metastatic setting, imatinib is the standard treatment, and it should be continued lifelong. There is no specific number of years that is mentioned in any of the guidelines. It is a lifelong treatment. Unfortunately, some patients do progress on imatinib, and these patients should be switched on to sumatinib. And if the patients progress even on sumatinib, the current guidelines suggest that they should be going on what is called the 3rd line therapy, which is regorafenib. Thank you very much for your patient listening. Thank you once again for giving me an opportunity to deliver this talk.